Hi, I'm John Ellis. I'm adjunct professor of anesthesiology and critical care at the University of Pennsylvania, and I'm giving a presentation that is in conjunction with Dr. Manny Fonts, who's at Duke University. And this talk is about really the physiology of blood pressure and the relationship to postoperative vascular complications and how pharmacologic therapy may improve upon outcome in these patients. Dr. Fonts has no industry conflicts to report. He has received funding from the Ischemia Research and Education Foundation for data that will be presented later in the talk. Dr. Ellis, I am a Speakers Bureau member and consultant with Baxter Pharmaceutical. Now here's the question. Which are these appropriate blood pressures for our patients during surgery? And, we might find that some of us will differ in this. The other thing I want you to notice here is that all of these patients have somewhat similar pulse pressures. And a good bit of what we're going to talk about today is not just the importance of systolic or diastolic pressure, but it's the importance of pulse pressure. Now, the Joint National Commission in the United States has every few years come up with guidelines and recommendations for care of patients with hypertension. In JNC 6, which was some years ago, we're currently on JNC 7. They defined a number of categories of blood pressure: optimal, less than 120/80, normal in this range, borderline hypertensive in this range, and then hypertension. They define several stages of hypertension depending on how bad the hypertension is. Okay, again, you see here's JNC 6 in 1997, JNC 7 in 2003, and JNC 8 is expected soon. It does not yet seem to be available, but it will be published on this website. This is the National Heart and Lung Blood Institute of the National Institutes of Health in the United States. What's defined as hypertensive emergency, and we've all seen this in patients perioperatively, is when the blood pressure is greater than 180/120 and complicated by evidence of impending or progressive end organ damage. Hypertensive urgency is similarly severe elevation in blood pressure without progressive end organ damage, at least yet so far. Now, what's interesting to note is that risk chronically begins at much lower blood pressures. Risk begins, in fact, at 115/75. A 10 millimeter increase in systolic blood pressure increases CNS complications by 40%. A 5 millimeter increase in diastolic blood pressure increases ischemic heart disease complications by 30%. And because of this, we now have revised thresholds for patients with diabetes and renal disease, with recommendations that they be tightly controlled and managed to blood pressures of less than 130/75 so as not to worsen their propensity to go on to renal failure. Now, what we know is that patients over time tend to become hypertensive. This is in women and men over age 65. And you see here that over the period of years of follow-up, both in the 1970s to 1998 period as well as an earlier period, the majority of people will go on to develop hypertension. And so, as we know, this is a problem we face daily in our clinical practice. What we also know is that patients who have prehypertension are much more likely to go on and have coronary heart disease. And so just having prehypertension in itself is a risk factor of development of coronary disease. Fortunately, what we do know is that the age-adjusted mortality for coronary heart disease has been declining, at least in the United States, and this is in part due to the greater recognition of hypertension and the greater and better treatment of hypertension in patients. We also have seen a decline in age-adjusted mortality for stroke, and that is another promising aspect of better control of blood pressure. Now, what one hopes to do is to get blood pressure reduced And as we reduce blood pressure by relatively small amounts, we can see reductions in stroke mortality, coronary heart disease mortality, and overall mortality. Just 5 millimeters of mercury reduction can result in significant reductions in mortality rate. Now the question is, should we be addressing the systolic pressure, the diastolic pressure? And in this lecture we'll particularly focus on the pulse pressure, that is the difference between systolic and diastolic pressures. What we find is that at age less than 50, diastolic blood pressure is the greatest predictor of risk. From age 50 to 60, where I live, all three are equally predictive, but as patients are over 60 years old, pulse pressure becomes the strongest predictor of adverse outcome. So we see here, for example, that not only is that an issue as far as the relationship to poor outcome, but we also see as men get older, systolic blood pressure goes up and diastolic pressure falls. So the pulse pressure increases significantly. We also see the same in women as they approach 80 years of age. The question then is, for patients who are hypertensive and coming for surgery, what is the relationship between these different subsets of preoperative hypertension, systolic, diastolic, and pulse pressure, and major postoperative outcomes? And so the McSpy multicenter study for ischemia and epidemiology investigators who are here, some of them at Duke University, Barish at Yale, Mangano in San Francisco, in addition to Dr. Matthew at Duke, looked at this in a series of studies. What they wanted to look at is what was the relationship between high blood pressure and coronary outcomes, renal outcomes, brain outcomes in patients undergoing CABG. And this was a multi-institutional study in 70 institutions in 17 countries. They collected 7,500 fields of data per patient. Okay, tremendous amount of intraoperative information, postoperative information. And what they found, and they published this several years ago, was that pulse pressure was associated with a risk of adverse outcome in coronary bypass surgery. If you look at brain outcomes, we see that pulse pressure in multivariable analysis is an independent predictor of adverse central nervous system events. Okay? Simply having an abnormally increased pulse pressure. We see that here. What about the kidney? They also found that as the pulse pressure increased, the likelihood of renal dysfunction after CABG increased as well. Then even looking at survival after surgery, we see here that the patients with event-free survival, so that's not having death or morbidity, we see here that patients who have a pulse pressure of greater than 80, approximately 40% of them have some sort of event during this period of time in the first month after surgery, and that's much greater than the patients who have lower pulse pressures. Other workers have shown that pulse pressure is an age-independent predictor of stroke after cardiac surgery, and this is from the group at Johns Hopkins in Baltimore in the U.S. Again, the larger the pulse pressure, the more likely patients are to have CNS accidents after cardiac surgery. This has also been shown in Dr. Fons and his group that this predicts long-term mortality as well. Higher pulse pressure is associated with worse outcome in terms of survival after coronary artery bypass surgery. Why might this be? Well, what happens is that the arterial vascular function has really two purposes. One is as a conduit to maintain perfusion pressure to the tissues, and the other is to provide cushioning, to provide a pulsatile, smooth flow. And what happens is in elderly patients, this function is lost, and in fact, what you have happen is the opposite. Between coronary disease, microvascular disease, this makes transmission of pulse pressure to the microvasculature less likely to happen. And this is particularly because pulse wave velocity is increased in elderly patients who have large artery stiffness. Their arteries are no longer able to relax, to absorb some of the initial output of the heart, and then provide perfusion throughout the cardiac cycle. We can think about this like a wave. This we can think of as the central wave as the initial ejection from the heart, and it looks something like this when it gets to the periphery. But then there's pulse wave reflection, which is equivalent to a wave hitting a rock. And in elderly patients who have stiff blood vessels, they will have more of a pulse wave reflection, and that may tend to augment pressure there. Now, what we normally know is that from the central circulation, as you go further out, as the blood pressure wave propagates, you tend to see some increase in pulse pressure. And this is normal even in healthy young people. And you see here you have a propagated wave, and then you have a somewhat delayed reflected wave, and these are summed together to provide a pulse pressure. And we measure the pulse pressure right there. And however, as in this case, people we see at age 24, not a tremendous amount of augmentation as you get out into the peripheral circulation. With older people, there's much more of reflection of waves and a much larger systolic pressure here from augmentation that's coming back from the periphery. And these are two patients that may even have the same mean arterial pressure in terms of area under the curve, but you see much more of a spike of systolic pressure in these older patients with stiff arteries. The other question that Fons and his group, Solomon Aronson, former colleague, asked was whether or not there's a relationship between control of blood pressure with a variety of medications and outcomes in patients undergoing cardiac surgery. Let me just say that here patients were randomized in this trial to either nitroglycerin, sodium nitroprusside, nicardipine, and clevidipine, another short-acting calcium channel blocker. And what they wanted to do here was measure the area under the curve of time when the blood pressure was out of bounds. So they set what they thought were normal limits of blood pressure, and they integrated this area that was out of bounds, either high blood pressure or low blood pressure. The less area under the curve, the better the blood pressure. The more area outside of the curve, outside of the limits, but under these curves here, the poorer blood pressure control is. And what they saw here, for every 1 millimeter of mercury times 60 minutes of time that the systolic blood pressure was above or below what was considered to be the normal range, and the normal range was 85 to 145 before and after surgery, or 75 to 135. These are very generous ranges intraoperatively. The more time patients spent with their systolic blood pressure outside of this range, the more likely they were to have 30-day mortality. So again, poor control of hypertension was associated with increased mortality at 30 days after CABG surgery. In fact, in one study, the impact of pulse pressure is more important than cardiac diastolic dysfunction on intraoperative hemodynamic instability. So what are our management issues then? We need to ask ourselves, and we probably have more questions than answers now, what should the threshold of diastolic blood pressure be? Of systolic blood pressure? Of the pulse pressure? And we have to realize that our antihypertensives may not be particularly selective for one or another of these different types of hypertension. And in fact, we have a relatively poor understanding, inadequate teaching and awareness of isolated systolic hypertension and pulse pressure and diastolic hypotension. So the take-home message here is that the arterial pulse really is a complex physiologic parameter. And while we typically focus on the systolic and the diastolic blood pressures, we also need to look at the pulse pressure and know that this is a risk factor for adverse outcome. And we believe there's a need for a paradigm shift in terms of monitoring, in terms of treatment. We do see here that better blood pressure control in patients undergoing CABG is associated with better outcome. Patient counseling for chronic control of blood pressure, and certainly more research in this area is needed in the future. Thank you so much.